Good afternoon, everybody. This is Madeline Wilson at the Indiana Hospital Association, and thank you for taking some time to join us on a call today to talk about pressure ulcer prevalence. We're going to kind of take a look at some of the data right now, what we're seeing through the HIN program, and also some of the internal data that we are looking at with DataLink. I know some of you are familiar with using that tool. That is a newer tool that IHA is working with. And so I really kind of wanted to share with you all what the data looks like. And I have some questions as well because some of it just looks a little bit odd. So I thought it would be a good time to bring everybody together on the phone call and make sure that we're all on the same page with how we collect prevalence data. So our objective today of the call is to review the definition of pressure injury prevalence and the HIN data to ensure that we're really capturing the correct data for this. I have some discussion around barriers and how we can prevent skin injuries, and also reviewing some resources to assist with reducing the harms from pressure injuries. So I wanted to start off right now by giving the HIN definition of prevalence. I know that, we started this program, almost 3 years, well, it's been 3 years almost. And so kind of once we get into the swing of this, we start collecting the data, we kind of forget about what we were actually looking at, if the definitions have changed or anything that's happened along the way. And one thing that has made a change in the HIN programming is pretty much the first, I would say the first couple of years, their focus was really on the stage 3 pressure injuries, 3 and above, but now they've changed their focus to looking at the prevalence data because they see another opportunity in looking at prevalence is kind of making sure that your patients never progress to that higher stage or any stage at all of pressure injuries. And so now their focus changed. Because of that change in focus, I've had an opportunity as the lead for pressure injuries to really look at all of our hospital's data and kind of I've seen some interesting things about it. So I thought I would start off by talking about the actual definition, and this will be really important because we want to make sure that what you're recording for your total number of injuries is following the encyclopedia of measures. And so I wanted to point out to you here that the numerator is the number of patients that have at least one stage 2 hospital-acquired pressure injury or ulcer, an unstageable or a DTI, deep tissue injury, on the day that you actually do that prevalence study. And also, remember, you're not counting how many ulcers you have, but rather how many patients. So the day that you do your prevalence study, your denominator is going to be the total number of patients that you laid eyes on that day to do that study. But your numerator, and this is the buzzwords, your numerator should be hospital-acquired ulcers, and that is on the day that you do your prevalence study. So that doesn't mean the present on admissions. That is only the ones that you know those patients did not come in with when they were admitted. And so that is so very important because when I look at some of the high numbers with some of our facilities, it really kind of makes me wonder if that total number that's being recorded for that month or that, for this case it would be the day of your prevalence study, if that's including all of the pressure injuries that are in your hospital on that day of that study. So that is one very, very important thing to remember. If you also look on here too, you will also see that there are exclusions to that numerator. And obviously the very first one is present on admission, patients refusing assessment, patients who are off the unit at the time of the study. I mean, some of these are no-brainers. Medically unstable patients are those for whom assessment is contraindicated, so the ones you can't turn. And here's one, patients who are actively dying and pressure ulcer prevention is no longer a treatment goal. Moisture-associated skin damage, skin tears, venous arteriostasis ulcers, or mucosal membrane ulcers. So those are exclusions of your numerators as well. So hopefully you're looking at these numbers when you're doing your prevalence and you're able to sort those patients out and not keep those in the total number for the purpose of your recordings in the HRET HIN system. So how did we come up with this diagnosis? This follows the National Quality Forum definition, and this is right on the Encyclopedia of Measure page that you'll see. So once again, it talks about, the patients that have at least one category, stage 2 or greater hospital-acquired pressure ulcer on the day of the prevalence measurement episode. So it follows all of these same criteria that you will see in the HIN Encyclopedia of Measures. So let's take a look at the data. So when I run an improvement calculator, the data, we're looking at the data that is currently reported through August. Now, we just have, last week, had the requirement that you needed to have all of your data at least through July. So I would say the majority of you have July data, and then we have some that already have August and September data as well. So there's no certain cutoff. This is just our total right now. When we started the program, which began in the October of 2016 data monitoring period, the baseline rate was at 5.25 with a monthly baseline numerator of 50.72. Now, that is for 92 hospitals, so that's why that number is so high. And the baseline denominator was 9,661. Currently, our rate is 5.18. So as you can see, we've made a couple of baby steps towards improvement. We were, about 6 months ago, really at a good place of improvement, and we have declined a lot since then. Our project numerator through August is 723. So that means we have 723 recorded pressure injuries that were hospital acquired and counted on prevalence study for all 92 of our hospitals. Pretty high number if you think about that. Our target rate for improvement for 20% for the HIN period, which will end the end of March, is 4.2. And as you can see, we're at 5.18. Right now, that equates to a 1% improvement. So that's why HRET has made this a focus for us to look at and see, what's going on in Indiana with our pressure injuries, and especially as it pertains to prevalence. So this is what the snapshot looks like, our trends since our baseline period in October of 2016. And as you can see, it's been very interesting. Looks a little tacky, if you ask me. We have a good month, and then we have a not so good month, and then we have a good month, and then we go back down, and we go up, and we go down. Interestingly enough, I put a couple arrows in there because if you recall, last January and March, we offered 2 wound care trainings. And I will tell you, when those trainings were offered, I was forewarned that we would see a spike in our our stage 2s and in our prevalence study, but that would be okay because sometimes that is perhaps an organization really learning how to assess their patients and that they're catching more that maybe they weren't catching in the past. And as you can see, we did take that little spike, and then we took a great nosedive down, came up again, and we went down, and as you can see, we're kind of staying below our target line, which is the bottom line in green. So for that, I'm very excited. I just don't want to see that line go back up, and it would be really good to get our improvement back up. So data link. So data link is our program right now that we rolled out a few months ago, and we've offered to our quality leaders. And if you recall, a lot of times myself and Annette Handy and Becky Hancock, when we attend your Safety Coalition meetings, we have brought in reports, and we've called them the candy cane reports because they're red and white, but they actually have it documented where your data's at. Included in that, we gave you another report, which was your sepsis report, and in the past we gave you readmissions reports. Well, this is all now moved into a new program called Data Link, and there is access for you to go into there and see your personal organization data for, we're looking at sepsis and readmissions, and we're now expanding on some other areas as well. We're going to be building on health equity and then looking at some other socio-related statistics as well. So when I went into Data Link, I was actually able to look at everybody as a whole and kind of assess how many you all have reported on your prevalence study. And to date, as of this morning when I reran this report, there are 891 documented stage 2 or above hospital-acquired pressure injuries that were found during that one-day prevalence study. 891 for 92 hospitals, and that is from October of 2016. Pretty high number. So now I want to flip it real quick and look at the stage 3 definition so you can see the difference between that. Obviously, the stage 3 follows that is the ARC patient safety indicator number 3, and that is the data that we enter on your behalf if you have given us the permission to enter that information into the HRET/CDS system for you. And we do that for almost 100% of our HIN hospitals. So you may not ever really look at that number unless you're looking closely at your data. And I'll tell you that is really important for you to take a look at. The numerator for this is a little bit different than obviously than the prevalence study. It is discharges with any secondary diagnosis code for pressure ulcer stage 3, 4, or unstageable. So not 2, but 3, 4, or unstageable. We get that information from your claims data. So every hospital in the state of Indiana submits their claims data to the Indiana Hospital Association, to our data team, who then takes all of your claims data and puts it in the inpatient discharge and outpatient discharge study for the Indiana State Department of Health. So we're the vendor who does that work. And while we have all that claims data, we are also able to help you out with getting that information put into the HIN HRET system for 6 of the measures. They're the sepsis measures and the ARC measures, along with readmission, so that is one less thing for you to have to put in the system. But one thing I wanted to draw your attention to is, have you ever really looked at that data after we have put that in? I do know I have had a few organizations that we've been able to discern that they have this high volume of prevalence numbers, and then when you get to the stage 3 and above, they have 0. And so that could be one of two things. It could be a celebration because the pressure injury never made it to a stage 3, or there could be a problem with how those are being coded. And as I said, I know I've had some organizations that are like, well, wait a minute, I know we've had a stage 3, I know we've had a stage 4, why is my number 0? So that's when you have to go back to your coding department and you have to take a look at these records and find out what were they not able to see that helped to ensure that that number was appropriately coded. Very, very important. And so validation of that data is something you might want to put your eye on. The next time you go in there, just take a look, just scan your numbers. You know, when you go to enter the data, you can see all of your results right there. And if you see a bunch of zeros and you know that you have had a stage 3 or 4 or unstageable, then it would be worth some investigating to find out why that chart did not get coded as such. Now granted, nobody wants to have those coded, but at the same time you want to make sure your data is valid, because if you're audited and it comes back to that, you know, then you have a bigger problem. And also, if you do know you have a stage 3 or 4, not unstageable, but a stage 3 or 4, it is mandatory that that is reported to the Indiana State Department of Health, to the medical error site, and you know, those are tracked as well. The difference between the HIN definition and the Indiana State Department of Health definition is the Indiana State Department of Health does not count unstageables, only levels 3 and 4. So you know, those are required to be reported. So I ask you to kind of take a look and make sure that your data is correct from that standpoint as well. So when you look at the stage 3 data, when I pull up the improvement calculator, I came up with 118 stage 3, 4, or that's supposed to say unstageable hospital-acquired pressure injuries, not unstable. But so that's 118. So my question is, do we really have that many stage 2 hospital-acquired pressure injuries? And what I mean by that, if you recall back on my previous slide, there were over 800 reported stage 2 or above for prevalence study, but there's only 118 that fall into that category of stage 3, 4, and unstageables. Now, I say only, even though that, you know, 0 is always our goal, right? Some we can't help, but my question is, this is what led me to believe, do we really have, are we really recording only hospital-acquired pressure injuries on the day of the prevalence studies? So that's my $100 question, and that's actually a question that's been presented to me from HRET to take a look at our data over. So when, you know, this is Indiana is not unique, okay, with the pressure injuries. Like I said, we were really on an upward trend with both the stage 3, 4, and unstageable and our prevalence study, and somehow we've kind of fallen off the wagon with this. And when we noticed we were starting to trend down, we were invited to participate in one of the HRET's programs called the Sprint. We did have several hospitals that participated in it, and it was really some aha moments that we got from that. And that is where we found some people were not collecting the data appropriately, and also that's where we found out that hospitals were like, yeah, we know we've had some stage 3 and 4s, but yet when we looked at the data, it said that they had none. So we were able to find out that there were some coding situations. And so, you know, we can start working with the hospital teams to make sure that the documentation is in line with what, you know, the bedside staff are assessing for. But through the sprint, we looked at common areas where they were discovered, and also what were some opportunities for helping in skin prevention. And so, you know, some of this is nothing new. You know, the main locations on the back side and the buttocks, the sacrum and the cockpit, and of course the heels. Most of them were discovered in the ICU, but the million-dollar question is, you know, what's coming out of the emergency departments as well? And I also, it's not on here, but another area is surgery. You know, the patients that are laying on the tables in one position for multiple hours for big procedures. Are we causing some pressure injuries to begin there? Same thing in the emergency department. You know, are your patients spending a lot of time in the ED while perhaps they're waiting for bed placement and they're on the carts, the very uncomfortable carts? And so, you know, a lot of times that's where these injuries are beginning. So those are areas, opportunities to look at. For preventing these occurring, so some opportunities that we saw are the education of patients and families and engaging them, and this is very, very important. You know, you might have some patients that come in and they have been in the recliner, they've been bedridden, and even though that first assessment that you do, you may not really get that area, it might not make it, you know, in your eyes as an area of question, but, you know, the patient's with us and 2 days later, all of a sudden, there's a big wound that's festered, and, you know, was that brewing before they came in? So the education to patients and family about good skin care is very, very important. Improving early detection, as I just said, you know, what state are these patients coming to you in, and are we really, really doing a good skin assessment? An active support surface in the emergency department. You have a patient that you know you're going to be in the having in the ED for a while, making sure that they are, you know, put them on an egg crate, get them in another bed if you can, but making sure that they're not on that surface that could enhance that area that has potential breakdown. Making sure about the head of the bed elevation and making sure that these patients are being moved and turned. Immediately getting that barrier cream put on when you have an area that's a high moisture area. Once again, making sure that you don't have a time delay and making sure that they're on the right surfaces, taking a look and protecting those heels, and most importantly, mobilizing the patients using your equipment that you have, not sliding them and having the friction and the shear, but utilizing your lift equipment. So of all of the hospitals nationwide that participated in the sprint, these were the top areas that were noted for opportunities and where injuries occur. There is a tool, like many tools that HRET has promoted, but it's called the Happy PI tool. And I like to share this when I'm working with hospitals because it's really a good evaluation tool to kind of address your gap analysis. This tool has been used in the sprints. This is the PI tool for the pressure injuries. There are similar tools for other harms as well. But you should really look at your patients that you have identified as hospital-acquired pressure injuries. And if you follow these questions, when you're done with this and you have all of your cases lined up on here, you really can see where your gaps of care are. You can find this tool at this website. And by the way, there will be a recording of this webinar, and also the slides will be available within the next few days on the IHA website, so you will have access to this. Anywhere you see the bright blue underlined information, that is the actual resource site that you'll be able to obtain this document. So this tool is 2 pages, and it asks all of these specific questions that will help you see where perhaps you need the most improvement in your injury prevention plans. So prevention. So healthy skin. You know, one thing that is so important is nutrition. Excuse me. And it's kind of funny when you use the letter skin, this equals healthy skin. So skin inspection, keep moving, the incontinence prevention, and nutrition and hydration. How many patients come to us either malnourished or severely dehydrated? You know, your skin is another organ, and if we're not hydrating, if we're not nourishing, our skin is not healthy. And it just sets us up for failure in that harm prevention. So something to really look at, and don't hesitate to get that nutritional consult right away. It is very, very important. This is a great literature piece on the importance and the role of nutrition for pressure ulcer management. So I've provided the link here for you to go ahead and take a look at it. Great white paper, but if you're not looking at implementing a nutritional consult for these patients that, you know, that when you do that first assessment and you identify that, you might want to consider making sure that that is being completed, and you might be able to pick up on that when you do your gap analysis. Patient and family engagement matters. I've put 2 tools on here that 2 different hospitals have developed, and these are information sheets that actually you give to the patient and the patient family, and you talk about, you know, what are the risks and what can people do to make sure that they keep their skin healthy. Because, as I said, sometimes we get these patients in our facilities, and, you know, when we do that first assessment, the first quick look doesn't necessarily show that there are any problems, but day 2, all of a sudden, you have a big festering wound. And so it's really good that we do some education. And you know, our MVP patients, our multi-visit patients that come and go, our little frail elderly folks as well, education is really, really important, and to keep them out of the hospital. So I've given you 2 examples here that you can see what other hospitals have done, and, you know, feel free to kind of look at this and design your own patient education if this isn't something that you're currently doing. So I wanted to include some resources again. The HRET change package, if you haven't looked at it, I recommend that you pull it up and kind of take a look at this as well. This will kind of give you some tips, and there are multiple resources listed in it as well. And then two other very, very good educational pieces that I wanted to point out to you. I've had some requests from hospital asking, are there any videos that we can use for our competency, or either, you know, our new staff orientation or our annual competencies? And ARC has a really, really good YouTube video about conducting a comprehensive skin assessment. So I've provided the link to that. But ARC also has a really great tool that you can use for educational purposes on preventing pressure injuries in the hospital. So this tool is customizable for your facility. So I've also given you the link to use that as well. So this is my help that I'd like to offer to you. If you can take a look, especially if you're on this call today and you're questioning, saying, maybe I really ought to take a look and see how many of these prevalence pressure injuries we're documenting. It's kind of when you go month by month and you see maybe 2 or 3, it is not probably as overwhelming until you look at your total. And then when you see, there's 110 or something to that effect, you might want to take a look back and see, did we record the right numbers? It might be a little bit of work for you, so however I can help you with that, please don't hesitate to reach out to me, and we can work on it together. Numbers can be fixed in the system if you found that you have reported excuse me, more numbers than what you actually have that meets the definition. It's really a simple fix, and I will be glad to take care of that for you. But I'd really like to ask if you can all please take a look at your numbers and make sure that you have the appropriately recorded numbers down. And so right now I'd like to, we'll open up all the lines and see if anybody has any questions. And the lines are now open.
Uh-oh, what if we both have that? What if we both have that mantra? Oh dear.
So do we have any questions?
Super, super boring. Super boring.
If you're online, if you have, do you have anything you want to chat in? Well, all right. As I said, we'll be posting this to our IHA website, so you'll have access to these resources. My contact information is on here as well. And I just wanted to give you a heads up that in the first quarter, so I'm looking at probably February, we will be offering another wound care training. We offered 2 of those last year, and we're going to be bringing Nancy Morgan back. And it will be a different training this time. It will not be the same. So we're really, I've been working with Nancy, and we're going to look at our data and find out what our true needs are so we can educate to what the needs of you all are. So stay tuned for that. Thank you again for joining us today. And as I said, if you have any questions or you need help going through your data, please don't hesitate to reach out to me. So everyone, have a great afternoon.